Hello, Dr. Leslie Schover.
Selma, it is so great to see you.
You're a pioneer in your area. You are a professor of behavioral science. Your area of specialty is sexuality, and the MD Anderson is really lucky to have you.
Well, thank you. I hope they think so.
You truly have pioneered an area in oncology, psychosocial oncology, but the area of sexuality in some way has, until you, has been sort of shoved in the back, and you have helped to not only shed light on it, but to bring it out so far in the open. And your recent publication and the presentations here at ASCO, I could tell from the physicians that were running into that session that you have overcome some really significant barriers.
You know, it has been a kind of a passion of mine, I guess, because as a clinician and a researcher, I get angry if I think patients don't get accurate information at the time that they need it. And you see so much misery that could have been avoided with not that much effort. And even though things have improved, I like to contrast what's happened with sexuality to the oncofertility issues, because I think everybody is like, oh boy, cancer patients having children, it's like mom and apple pie. And so when some of the new techniques became available, this rush to, for research funding and for all the cancer centers to have programs happened so fast, and sexuality is kind of lumped along, even though it affects a lot more of our cancer patients and survivors.
What frustrates me still, as I know you will agree with this, that when one sees their medical oncologist and before they ever start treatment, the discussion of body image, sexuality, fertility, all of these things really need to be part of that dialogue early on. And I think that for a physician to feel comfortable engaging in that discussion that deals with sexuality, he or she has to be comfortable enough in their own ability to talk about sex. And it's sort of like a therapist who's had a great life experience and a rich life experience has that much more to impart to their patient. So a doctor that has difficulty talking about sex, and you go into your clinical setting and you've got to have that discussion, I am so concerned, because it's part of the continuum of care that has to be addressed.
Well, I think the other issue is that we ask oncologists to see more patients in less time, and there are so many complex issues that need to be discussed at the time of treatment choice and even at follow-up. And I think I've gotten over ever expecting that all but a very few very enthusiastic oncologists are going to do sexuality counseling. But what I ask them to do is bring up the issue and say, look, your treatment could affect your sexual function, and here is our site team specialist, who may be their advanced practice nurse or social worker or physician's assistant or psychologist if they're lucky, who can sit down with you and discuss some of these things in detail.
But maybe you could just take a few bullet points for the viewers, who are mostly patients and survivors, and sort of summarize everything and leave us with the bulleted points that we need to carry with us.
Well, the first thing I wanted to get across is how common sexual problems are, especially if we look at survivorship, because 69% of survivors have cancer sites where treatment typically leaves at least half of people with long-term sexual problems. And we know from study after study says that these problems don't go away by themselves. So, if you're mildly depressed or certainly anxious at the time of cancer diagnosis, if your treatment goes well and you're free of disease a year later, usually those things resolve, but the sexual problems don't resolve. And also, certainly body image and relationship issues are very important and interact with things, but frankly, our cancer treatments do physical damage to the systems that underlie a normal sexual response. So pelvic surgery in men, disrupts erections by damaging nerves and blood vessels. In both genders, pelvic radiation therapy does tissue damage in the genital area and disrupts blood flow that you need for vaginal expansion and lubrication and for erection in men. And in women, one of the groups most at risk for sexual problems are younger women who get either chemo, pelvic radiation, or have both ovaries removed and end up in an abrupt premature menopause. Or older women who are taking estrogen, although that's a little less common nowadays, and have to abruptly stop it as a result of their cancer diagnosis. So they have much more severe symptoms in terms of hot flashes, vaginal dryness, pain with intercourse. And I think that those often lead into losing interest in sex. And also, I think we need to recognize that people who go through really intensive chemotherapy, either as a preparation for a transplant or just as a treatment for their cancer, often end up with unrecognized hormone abnormalities. In the case of men, they have chronic fatigue. If they've had an allogeneic transplant and end up with graft versus host disease, the women have some horrendous vaginal complications that can occur. And some of these things, you know, it's much better if you treat them early rather than leaving them go, because there's more that you can do to prevent a more severe sexual problem. So recognizing the symptoms early and getting some help is really important.
Well, and if you're not with a physician who is entirely comfortable, the patient can look at the doctor and say, hey, I'd really like to talk to someone, and you know your physician would be able to set up a referral for a more lengthy discussion with someone who can address these sexual issues.
The model I like is that every site-specific team in a cancer center or every private practice oncology office should have somebody who knows enough to sit down with patients, explain what's likely to happen, do some very basic counseling, hand out educational materials, and they should have a referral network of the people who are more expert or have, you know, more resources to deal with people when they have really complex problems that don't go away with just, you know, some suggestions for self-help or a pill or a hormone.
Well, I think all of us will be looking forward to what's next in your research.
I have 2 small business grants from the National Cancer Institute, and I'm developing multimedia educational and counseling tools, one for men and one for women, that cover both sexuality and fertility issues. And what I'm hoping is they will become a resource so that when people are diagnosed, or if the long-term survivors, the whole continuum,
Yes.
they can refer to this and get the information they need when they need it.
Thank you, Dr. Leslie Schover, Professor of Behavioral Science from the MD Anderson.
Thank you, Selma.
Thanks, Leslie.